It's my pleasure to welcome Dr. Berish Rubin. He has a degree in biology from City College and a PhD at City University of New York. He did his postdoc at Memorial Sloan Kettering, and he spent time at the head of the Lymphokine Laboratory at NYU and New York Blood Center before he became chairman of biology at Fordham, where he's currently a professor and the head of the laboratory for Familial Dysautonomia. And he is credited with discovering the gene that causes familial dysautonomia in over 100 publications in peer-reviewed journals. On a personal note, the healthcare providers here at Robert Wood would like to thank Dr. Rubin for being available 24 hours a day, as we call him, to help manage these very interesting and, for me, quite scary patients. So without further ado, Dr.
Thank you, and thank you for coming. I'm not going to take up a lot of time with the thank yous. I just also would like to acknowledge Dr. Neil Gittleman, who has done an incredible job with this patient population and has an incredible amount of patience for me, even when I call him sometimes at 4 in the morning with either an idea or a challenge with one of the patients. So I appreciate that. So the title of the talk today is Reversing the Course of Familial Dysautonomia by Modulating the Impact of the Disease-Causing Mutation, a Model for Other Genetic Diseases. And my goal is to cover a reasonable amount of territory and give you an overview of the field of familial dysautonomia, and then if there'll be specific questions, I'll be happy to address them later on. FD, or familial dysautonomia, is a recessive disease. It's primarily found in individuals of Ashkenazic Jewish descent, though we have found the mutation in a non-Jewish population. The carrier frequency in this population is about 1 in 30, and it affects the development and survival of sensory, sympathetic, and parasympathetic neurons. These are the typical symptoms that one would find in an individual with familial dysautonomia. It's usually detected at birth. There's a weak or an absent sucking. There's generally an absence of tears. There are these intense hypertensive vomiting crises that these children go through, decreased sensitivity to pain and heat, cardiovascular instability, speech and motor coordination, unsteady gait, and this was one of the characteristics of the disease as well, reduced life expectancy. Our introduction into the field of familial dysautonomia actually began in 2000 as a summer project for some students in the lab, and like a guest that doesn't know when to leave, I'm still working on familial dysautonomia. I was very involved in immunomodulators before that, and this field had kind of caught my interest, and I've been there ever since. So we reported in 2001 that it is caused by a mutation in the ICAP gene, and the mutation is very apparent here when you look at this sequencing gel. This is a normal individual, and you can see the lanes are labeled GATC, so the sequence here is GT in the normal individual, and when you go and look at the individuals who were affected, we found that in place of that T, there was a C. So the question is, where is this mutation and what is the impact of this mutation? It turns out that this mutation, well, the normal sequence, is located at the splice site between on intron 20, between exon 20 and exon 21. Normally, splicing will occur, which will connect 19 to 20, 20 to 21, and so on and so forth. In individuals who have familial dysautonomia, 99% of the cases, the mutation is this change here to the C in this position. And the question is, what was the impact, or what is the impact of this C in this position? So we generated primers to analyze the RNA that is produced in normal individuals and individuals with familial dysautonomia to see how it is that this exon behaves in individuals with familial dysautonomia, or FD. And what we found is when we looked at the RNA of a normal individual at that region, we found a piece which was in excess of 200 base pairs. But when we looked at carriers, we found 2 bands, and when we looked at an infected individual, we found primarily 1 band. So it was impacting the size of the RNA that was produced in this region. And what we eventually realized after doing the sequencing is you're getting a skipping of exon 20. The skipping of exon 20 results in a generation of a stop codon in exon 21, and the protein that's made by this transcript is truncated and non-functional. It's interesting when one looks at this sequence here, this GTAAGC, and notices this is the C that is the mutation. An analysis of hundreds of intronic splice sites for this demonstrates that the sequence here, the GT, are invariant. There's always a GT as the first basis, and then the relative size of these letters reflects the relative prevalence of those particular bases in those positions. So if you look at this, what you can see is you have GTAAGT, which is the primary one, but you can also have in that position a G, an A, and a C. So the question is, in light of the fact that there is a C that is present in something like 15 to 20% of normal intronic sites, the question is, why is that having this very potent effect? And is that potent effect one that is either on or off, or does that the presence of the C allow for some production of some functional transcript from this mutated gene? We went back and did some further analysis to try to determine and to analyze whether there is any functional gene product that is made from the FD allele. And what we in fact found is that there is a small amount of correctly spliced transcripts. So there is some amount of 1920 to 21. And it is our belief that that's what keeps these children alive, because we have now found a mutation that completely disrupts the function of this ICAP gene, and those children die within a few days of life. So this seems to be what is keeping these children alive, the leakiness of this mutation. So this is a picture that came out of a paper which was recently published, which simply shows what happens in this situation. You get a small amount of the full-length normal transcript, which is 1920-21, which gives you this green protein, and it represents, depending on which cells and what environment you're looking at, a small percentage of the protein comes out to be functional. Most of the transcript connects 19 to 21. You get a truncated protein and a non-functional protein. One can see this very clearly when one looks at the size of the RNA, as I mentioned before, to see this is what you would find if you did a RT-PCR, if you did an analysis of the transcript of a normal cells from a normal individual. And what you find in individuals with FD, both in vivo and in cells derived from them, is that there is a small amount of the normal transcript that's being made, but the primary transcript is a shorter one, the one that is missing exon 20. Well, the fact that this mutation leaked, it produced some functional gene product, prompted us to try to develop or identify other agents that are capable of modulating the amount of leakage that occurs. So we set up a high-throughput screening program where we looked at the impact of compounds, both pharmaceuticals and nutraceuticals, on FD-derived cells using RT-PCR, in which we were going to quantitate, and we quantitated the amount of functional transcript versus non-functional transcript. We have screened thousands of compounds. We have had success with pharmaceuticals as well as nutraceuticals. The pharmaceuticals, we have a paper which is actually about to go out on one of the pharmaceuticals that we found. Our goal here was, this is a patient population that had a reduced life expectancy, and our goal was to get these products into the patients as quickly as we possibly could. And when we found pharmaceuticals, we took an interest in it. When we found nutraceuticals, we moved faster because there would be no barrier to the entrance into this patient population. The first one we found, which we found in 2003, is there is a molecule known as tocotrienol, which is in the vitamin E family, which induces ICAP expression, and at that point we proposed that it was a possible therapy for familial dysautonomia. This is just an interesting picture that shows, this is a quantitative RT-PCR where you're looking at the amount of transcript that's made. These are the different forms of tocotrienols. These are the different concentrations that were used. And what you can see is that you have a very nice increase in the amount of produced. This is just an anomaly or a terminology that's used in PCR, in real-time PCR, where the value of 1 represents a doubling, a value of 2 represents 4 times as much, and so on and so forth. Interestingly enough, the tocopherols, which are the very related molecules, do not mediate this effect at all. So it is a very specific effect, specific to the tocotrienols. And when one looks at the level of the functional protein that is produced in the tocotrienol-treated cells, you can see that there is clearly more of the functional protein in those that were treated with tocotrienols as compared to those that were not treated with tocotrienols. And this was done obviously by Western blot analysis. So this is a picture that I'll come back to on various occasions. This is the normal situation where the full length is a small amount of the full length, and with regards to the truncated, it is the primary transcript that is made, or the primary protein that is made. The tocotrienols do something very interesting. They increase or upregulate gene expression of this gene. So what happens is you still have this same ratio. It doesn't change the splicing process. You still have this same ratio where you have 10 to 25% of it is the functional and 75 to 90% is the non-functional or the truncated. But because there is such a significant upregulation, the amount of this that is present in these cells has increased dramatically. So that is what the tocotrienols are doing, and I'll talk to you about compounds that change the splicing in a little bit. So the obvious question was, is this going to have any impact in the patient population? And we've looked at it from various points of view. This is looking at peripheral blood cells and looking at ICAP levels where the pre-supplementation, they had what we called a 1, and after supplementation with 100 milligrams per day, they had more than a doubling of the amount of functional ICAP that we could find in their peripheral blood cells. One of the characteristics of familial dysautonomia is these hypertensive crises, life-threatening hypertensive crises. And what we found was in the patient population that was taking the tocotrienols, 17.4% reported no impact, and 82.6% reported a reduction in the number of crises, and in that 82.6% there's this 39.1% that reported a complete cessation of crisis. So the ingestion of tocotrienols seemed to have significantly changed the course of these hypertensive events. One of the other things that is characteristic of individuals with familial dysautonomia is when they do exercise, they actually have a drop in their heart rate. It's kind of the opposite of what you would expect. And so you have a drop in their heart rate before tocotrienol supplementation, and then we did the same analysis after tocotrienol supplementation, and you can see that there is a physiological change occurring in these patients who are taking the tocotrienols. One of the other characteristics is that they have a reduced amount of tear production, which turns out to be very serious. Many of the older patients are blind because of the abrasions that they have gotten over the period of time because of lack of tear production. And what you can see here is the analysis that was done with regards to the volume that was generated before and after tocotrienol supplementation. Well, so we had found one compound, introduced it into the patient population and saw success, but even before we started analyzing the impact of the tocotrienols, we kept looking for additional compounds that could change the production or enhance the production of the functional transcript and functional protein. And the thing that was very interesting as you look at this sequence here, again, you see that the C is there, and the question is, why is this, the replacement of the T with the C, having such a negative impact on the inclusion of the exon 20 sequence? So that intrigued us, and what we said is, let's take a look at the exon and study the exon and see if the sequence in the exon is going to provide us with any insight as to why the C mutation is having such a positive, or such a detrimental, I should say, effect on this transcript. So I'm not going to go into all of the nuances of the splicing process. I just want to inform you that within exons there are elements that either promote or enhance the splicing process or silence the splicing process. So we wondered whether there might be some of these splicing silencers which have a tendency to reduce the efficiency of the inclusion of an exon, and that in conjunction with this T to C change is having an effect on the splicing of this transcript. And I promised you I wasn't going to show you a complex picture, and now I just broke my promise. The only thing I want you to see is that the ESS, which is the silencer or suppressor, binds these proteins called HNRNPs, and the binding of these HNRNPs blocks the splicing process. So it's a splicing silencing or suppressing. This is the ESSs, and the ESEs have the exact opposite effect, where they bind these SR proteins and facilitate the splicing process. So seeing and knowing that the ESSs interact with HNRNPs, we went ahead first to look at the exon 20 sequence, and in fact found that there were at least 2 silencing motifs present in this exon. And we wondered whether the presence of these silencers in conjunction with the mutation which is located at the site is resulting in the skipping of this exon. So again, reminding ourselves that the HNRNPs are an important player in facilitating the silencing that goes on by the ESS, we looked to see if there was any literature that talked about the regulation of HNRNPs. And we found this paper, which appeared in 2002, in which they report that epigallocatechin gallate, or EGCG, a compound which is present in many things, including green tea, they reported that it has the ability to significantly inhibit the expression of this HNRNP. So knowing that, it was a logical thing for us to do to see whether or not EGCG would have an effect on the splicing process. Well, the first thing we did is we looked at the effect of EGCG on the HNRNP B1 mRNA, and what you can see here is as you increase the concentration of EGCG, you get a suppression of the RNA for the HNRNP B1. And when one looks at this on a protein level, you get a very dramatic effect. So this is the untreated, and this is the treated EGCG. There is a very dramatic reduction in the amount of HNRNP B1 transcript and protein produced in cells exposed to EGCG. So this is a picture you've seen before. When you look at the RT-PCR product from normal cells over the region that we discussed before, which includes exon 20, you get a product which is 434 base pairs in length. And when you look at the FD-derived, which we talked about before as well, you get a small amount of the 434, and then primarily you get the transcript that's lacking exon 20. And when you treat with EGCG, you can see that you get a very different pattern generated. So that cells treated with EGCG are producing far more. The relative ratio has switched. Okay? This was a very exciting and interesting observation. And so what I showed you before is this is the normal situation, and tocotrienols, what they do is enhance the expression of the gene. They upregulate the gene, which causes for the production of more of both the full length and the truncated. But what happens actually with EGCG treatment is you get much more, you get 75 to 90% of the normal transcript and the normal protein made, and only a small amount of the truncated product. This was reported in 2003 as well, that it corrects the splicing, and this has become part of the therapeutic regimen for this patient population. And one of the things that we noted and published in the paper is that the combined treatment with EGCG and tocotrienols results in a synergistic production of the functional gene product. Some of you may have seen this paper. This paper came out last year. This is coming out of CHOP, where they studied a patient who was on the tocotrienols and green tea extract and reported a very different outcome for this patient after and during and after a surgical procedure than is classically known for individuals with familial dysautonomia. Just to give you some kind of frame of reference of what it is that this patient was taking, and this is a text that comes out of that publication, this child was taking 600 milligrams per day of the tocotrienols, and the child was taking 700 milligrams per day of the epigallocatechin gallate, the EGCG. I don't want to spend a lot of time on this. I just want to tell you that we published this paper in 2012, which has a very bold title, which is Nutraceutical-Mediated Restoration of Wild-Type Levels of ICAP-encoded ICAP protein in familial dysautonomia treated cells. And so basically, we have now found a way to restore the level of this gene product, functional gene product, to that of normal individuals. And I'm just going to show you two quick slides. The top one represents RNA levels, and the bottom one represents protein levels. And what you can see is this is the amount of RNA in untreated cells. This is the impact in this experiment of the EGCG. And we found a new compound, which is genistein, which has the ability to also enhance the production of the functional gene product by changing the splicing process. And when you use it in combination, the effect is extremely dramatic. So there is a very, very enhanced production of the functional gene product, and we did this both in two different FD cell lines. We did this also on the protein level, and this is the part that surprised us and excited us. On the protein level, this is the kind of response you see with EGCG. This is the kind of response you see with the genistein. When you do the genistein and the EGCG, you get far more of the protein. And when you compare the amount of protein in these cells as compared to normal non-FD cell lines, you actually have more of this protein present. And this has been repeated numerous times. So we've actually been able to restore in cells from this patient population the level of this transcript and functional protein to that of, or equivalent to that you would find in normal cells. Okay. So that gives you a little bit of background, and the reality is that a very large percentage of the population is now taking tocotrienols and EGCG and genistein. I want to talk to you briefly about the challenge that these children faced, and you'll see in a little bit that they're doing much better in that regard. You already saw that when I presented the data on the impact of the tocotrienols. I wanted to provide you with a description of the hypertensive or dysautonomic crisis that they go through, and I thought of no better place than to steal it out of the journal Pediatrics. There was an article not so long ago in there where, and I'm going to bore you, I'm actually going to read this if I may. Familial dysautonomia is a genetic disorder that has, as one of its most debilitating manifestations, frequent bouts of nausea that can escalate to a more pervasive dysautonomic crisis. In addition to severe nausea with retching, the dysautonomic crisis is associated with symptoms that suggest systemic sympathetic storm, because there can be hypertension, tachycardia, facial flushing, bronchorrhea, gasorrhea, and worsening of oral coordination, such that the child has difficulty swallowing secretions and is reluctant to speak. There's a general overwhelming feeling of discomfort resulting in negative personality changes such as whining or withdrawal. In 40% of the patients with FD, these crises occur with such regularity that there seems to be a link with circadian rhythms. For some patients, the crisis is a daily morning event that starts with a sympathetic surge accompanying arousal. And this didn't appear that long. It's a couple of years that this appeared in the literature. So one of the things that one gets to do when they're a professor at a university that has a very limited teaching load is you get to spend a lot of time thinking about a particular disorder, and I spend a lot of time thinking about a particular disorder, and speaking to parents on a regular basis and trying to understand what's going on in these children as best as I can. I've had extensive interviews with the parents and with the patients. And what we found was, and once you see this list, which took a long time to put together, you'll see that the list is a very interesting list of compounds. So nobody really understood what precipitated these crises, and people referred to them as being caused by circadian rhythms and barometric changes, and some children referred to it as a crisis monster. There was no way to know what was precipitating these events. So what we asked people to do is to call us after when their child was in an event and report what had gone on in the last period of time before the event. And after a while, we began to see a pattern developing where there were certain things that these children consumed prior to these hypertensive events. And as you look at this list, you'll see that all of these compounds contain tyramine. So, there is a very large amount of literature that goes back to the early 60s, which makes reference to the fact that individuals who were taking monoamine oxidase inhibitors had a sensitivity to tyramine. And this is a very well-known response. And when you look up the symptoms associated with the hypertensive events that occur in individuals on MAOIs who have eaten cheese, for example, you look through this list, and this list is really quite indistinguishable from the list that occurs, or just list that you would generate in an individual with FD who is undergoing a crisis event. So we asked the very simple question: what are the levels of the monoamine oxidase in this patient population? And what you can see is a normal individual, this is the level of ICAP, and this is the level of functional ICAP in an FD individual. And when we looked at the monoamine oxidase mRNA levels, what we found is in these cells there was a great reduction in the amount of this RNA that was present in these cells. And when one looks at a normal individual on the protein level and looks by Western blot analysis, you can see that there is far more monoamine oxidase protein in these cells than there are in these cells. Now, I had presented data before which talked about the impact of tocotrienols on the crisis event, and we could see that there was a positive impact. And the question obviously then is the tocotrienol administration having an effect not only on ICAP levels, but also on MAOA levels in peripheral blood of these individuals? And as you can see, the tocotrienols, as you saw before, increases ICAP levels in this patient population, but also significantly increases MAO levels. So what's quite amazing is that these children have been undergoing these crises for years and years and years, and it's only recently that we figured out what was precipitating these. But as you can see from this slide, despite the fact that some of the patients despite the fact that these patients were taking the tocotrienols, there is a reduction, but not an elimination in all of the patient population, which prompted us to develop a tyramine-free diet for these children. In generating a tyramine-free diet, this comes off of a website, FD Now, has had a very dramatic impact on the number of events that these children will have. So this cartoon is always nice to have a cartoon in every, I was taught they're supposed to have a cartoon in every talk, but the truth of the matter is the point here is the almost there. So the number of crisis events that occurred in these children had dropped off dramatically. But we had a few kids that would still go into crisis, and when we interviewed them, we could see no ingestion of tyramine. We could see nothing that would provide us with any insight into why these kids were still undergoing the crisis events. One night I'm thinking about this, lying in bed, and I say to myself, where the heck is the tyramine coming from? Because we know the tyramine is a trigger, and they're clearly not eating it. And I said to myself, I wonder if the body will produce tyramine as a function of the normal processes. And then I began wondering about the bacteria in the colon, and I wondered if the bacteria in the colon were converting tyrosine into tyramine. And so I dragged myself out of bed, and I found a paper that appeared in 1955, which talked about the formation of amines, including tyramine, by intestinal microorganisms. And there's additional literature on this that appears at various times that talks about urinary tyramine levels and the impact of intestinal microorganisms on the production of this. Well, so I had this one child that was constantly giving us problems. I called Dr. Gittleman, I think, very early one morning to discuss this with him. And so we know that it's the tyrosine that's converted into the tyramine. So the goal here was to eliminate tyrosine from this child's diet and see what happens to this child. What happened to the child was quite dramatic. 72 hours after coming off of protein, being on a protein-free diet, the child's crises disappeared. And from what we can tell, it changed the microorganisms present in his intestinal tract so that he was then crisis-free for a very extended period of time. So based on the observation that protein, or in particular tyrosine, is a problem for these individuals, we have made the recommendation that the children consume the recommended daily amount of protein and not more. We've also recommended that they consume it in the early part of the day so that the protein is not sitting for extended periods. High levels of protein are not sitting for extended periods in the gastrointestinal tract when there is no peristalsis and when they are asleep. One of the other things that Dr. Gittleman pointed out to me is that they make a formula which lacks both tyrosine and phenylalanine, and we've been able to use that in this patient population to give them the other amino acids, and they have responded very well to that. Whereas if you give them normal formula that contains tyrosine, they run into significant problems. So, going back to this this description, so these crises is a daily morning event that starts with and so on and so forth. When we took the kids and asked them to consume, or the parents to consume, the daily recommended amount of protein and to consume it early in the day, these events completely disappeared. And so we have patients ranging that we deal with from months to one of them is 40-something years old. In all of those individuals, these events have gone away. They are no longer experiencing the nausea. And so there is no circadian rhythm. If you understand what it is that's going on, this was, once we figured it out, it was a very easy problem to solve. I want to touch on one other topic, which I think you'll find interesting. So there are reports in the literature that familial dysautonomia and anesthesia are really a problem and don't go very well together. And there are papers on the management of these patients, and they talk about anesthetic problems. And then there's a paper that came out in '85. In addition to profound hypotension, this is in a patient that had undergone anesthesia. Unexpected respiratory depression occurred, which had not been previously described, and there were other unusual features that occurred. So, in the olden days, a lot of the children did not survive anesthesia. Well, I'm sure everybody's made the leap now. Everybody knows that monoamine oxidase inhibitors in general anesthesia have to be, anybody who's on a monoamine oxidase inhibitor has to be treated carefully by the anesthesiologist because they have certain sensitivities. And this piece of information, our ability to demonstrate that these children need to be treated like individuals who are on monoamine oxidase inhibitors when undergoing anesthesia, has had a profound effect on the treatment of this patient population. So in this paper, they discussed and demonstrated that a previous anesthesia was very problematic, and after the ingestion of the tocotrienols and the green tea extract, it was uneventful, and the knowledge to avoid drugs that should not be given to people on MAOIs, there was a very positive impact on this individual. And this child underwent an adenoidectomy, and for this child they used sevoflurane and propofol, completely uneventful. So I have to tell you this story because this just happened. We had a child in Florida that just underwent scoliosis surgery. The surgery was done on Friday. The anesthesiologist reported that the blood pressure of this child was more stable than the physicians who were doing the surgery. It went without, and this is just a quote from an email that she had sent me. I spoke to her yesterday because I wanted to know what did she end up using off of the list of things that can be used. So Precedex and propofol, completely uneventful. So what used to be a life-threatening procedure or life-threatening process is no longer the case. So at Robert Wood Johnson, you've so far, and we're going to send you more of these, you've so far seen children who have respiratory difficulties, and you've actually seen patients with hypertensive crisis. Respiratory difficulties are a challenge. The ability of these children to swallow accurately and not aspirate is something that challenges them. It's something that they are born with. That's part of their inability to suck when they're babies. And a lot of these kids microaspirate, and we recommend that those who do drink anything, it's either thickened or only water. but you have seen some of the patients who have come in with some respiratory challenges. You did have a patient recently who came in with hypertensive crisis, which was very easy to resolve. One of the triggers now for hypertensive crisis, because this child was not eating anything with tyramine, did not take any medications which were contraindicated. One of the triggers for crises, which was never understood, which is now understood, is constipation. If you have the food that has been eaten over a period of time sitting there, and if I can use the word fermenting, it's generating tyramine. And so this child presented, this child was given a soapy enema, and 24 hours later the child was perfectly fine. And this is happening this is still an event that happens in these patients. Okay, I did promise you that there was going to be a model for other genetic diseases, so I'm going to just take a moment to talk to you about the other genetic diseases. I have no idea what time it is. Somebody want to tell me what time it is?
8:46.
46, so we've got plenty of time. So, Fanconi anemia. Fanconi anemia is a disorder, a decreased bone marrow function, increased cancer risk, physical abnormalities, and one of the mutations that causes in the Ashkenazic Jewish population Fanconi anemia is this mutation which we refer to as IVS4 4A to T. Now, of course, I'm going to tell you what that is. It is again at this same site. It's a splicing mutation, but this time instead of being at the 6th position, which is the one we've talked about, it's at the 4th position where you have an A to T change. But as you can see here, there are maybe 15 to 20% of the normal splice sites have the T. So the question is again, can this mutation be modulated? Can the impact of this mutation be modulated in a manner which is very similar to that which we have done for familial dysautonomia? That's the normal sequence. That this is the mutation where there's a replacement of the 4th base. Instead of it being an A, it's a T. And it causes a skipping of exon 4. And we have been able to modulate it. It turns out that there is a paper that appeared in Blood, and I don't remember what year it is, where they actually describe the fact that this mutation, this same mutation, which causes a very severe phenotype in individuals of Ashkenazic Jewish descent, causes a very mild phenotype in people of Japanese extraction. And the speculation at that point was obviously the genetic background is very different for these two individuals, so that could be impacting. But we've now found out that there are food compounds that impact the splicing of this, and obviously the Japanese diet is very different than the Ashkenazic Jewish diet, and that's what seems to be impacting the very different phenotypes that are occurring. I ran into this, I was actually in Israel, and I got approached by a group that saw our paper. There are two papers that I just want to make reference to, which you'll see right away. So this is a study of individuals, this is beta thalassemia in southwest Iran. And what you'll see here is that this mutation here, which causes beta thalassemia in this population, is exactly the same mutation that occurs in FD. It's a T to C in the 6th position. In this area, it actually represents 4.25% of the population. But actually, in Israel, this study was done with this mutation, and these are the people that contacted me. It represents half of the thalassemia patients. And we have had success modulating the expression of the functional transcript and protein in cells and in constructs that represent this mutation. Spinal muscular atrophy. Sure you all know the story here. There are two genes that are next to each other. In spinal muscular atrophy, there is a loss of this. Often there is a loss of the SMN1 gene, leaving behind the SMN2 gene. The problem with the SMN2 gene is it doesn't generate much of a functional transcript. You'll see a parallel here as well. This is the SMN1 gene, which has a C in this position, and there's a T in this position in the SMN2. Well, it turns out that this C generates a splicing enhancer, an ESE. Okay? When this mutation occurs, you get the appearance, or you get the, in SMN1 and SMN2, they're almost identical. They are derived from the same origin. But what happened with SMN2 is that a mutation has been generated in SMN2 so that there is a T here which generates an ESS, a silencing or suppressing element. This transcript, the SMN1 transcript, generates 6 to 7 to 8, as you would expect normal splicing to occur. The transcript that's generated by the SMN2 connects 6 to 8 in 80% of the cases, but in 20% of the cases they do get the functional product. Okay? So again, this 20 to 80 is kind of a similar story. So we decided we're going to spend a little time looking at SMN and looking at the SMA patients and studying for what's happening in these patients. So what you see here is there's two transcripts that we can identify. The upper transcript is the 6 to 7 to 8, which is made from the SMN2 allele, and then the smaller one is the 6 to 8. And what we've been able to demonstrate, I hope you can see that there, is that we've been able to, with some of the things that we have identified, been able to shift this so that so much more of the functional transcript is made in cells from these patients. And I could talk about this and other things for hours, but I'm running out of time. I just want to throw this out because there are things to think about, and hopefully I've stimulated some interest and enthusiasm about some of these things. So Gaucher disease is this deficiency, and one of the things that you all know is that the presentation of these patients is very different. You can have siblings growing up in the same house. One is severely affected and one is not affected at all. It's ranging from no outward symptoms to severe disability and death. Many of the mutations in the GBA gene reduce but do not eliminate the activity. So they actually don't eliminate the activity, they just reduce it. So you even have literature which says that monozygotic twins have very different phenotypes. And the question is, why? So the why is, I can tell you that I had a graduate student work in the lab, and there are food substances and pharmaceuticals that suppress the level of the GBA gene transcript. So you might have individuals and that are presenting without symptoms because they're not being exposed to whatever this is that's suppressing the level of the functional gene product. So I guess the takeaway lesson is that there are late onset diseases. And the question is, why are there late onset diseases? And there have been people who have been working on delaying the onset of the late onset diseases. And so all of this ties together and reflects the fact that our bodies respond to the stimuli that we are exposed to, and we need to think about those stimuli as having either positive or negative effects on gene expression and on the splicing and the processing of transcripts. Thank you very much.